Oh, look who's here, everyone. Good morning, everyone. Hi, hello. Hi, Jennifer, Kim, Katrina, Anna, Jean, I just saw you. Let's see. We've got a full house. Lori Fry, so good to see you. Donna, Juliet, Weinhold, lovely. Elizabeth, love that you're here, as always. Pat Pine, we haven't seen you in a while. We have more people coming in, everybody. This is going to be a little bit of a hello to lots of people because we haven't had our Klatsch normally. So Patrick is really kicking it off on a great note today. Patrick McKeown. Just curious, out of hands, how many of you have had training and a class in breathing reeducation on any level? Okay. So a lot of you. This is great. Jennifer Blunston, so fantastic. Hi. I want to say hello to everyone. So just know that I'm super happy that we're here together. And if you're with the AOMT, meaning you've taken a class with us, you know, this is a weekly event, barring holidays, the Mayo Coffee Klatsch. And then we extend it in a kind of a monthly basis, opening it up. So the point is to get people in, because of what I've heard is that I really want to share what we're doing with a colleague or somebody so they understand what I'm looking at. So if that's the case, I really would love, they're always invited. Just reach out to me. And today we have Patrick McKeown, who is actually going to be really specific in talking about breathing reeducation. So essentially how oral breathing affects those who use CPAP and who have upper airway resistance. So I know this is a topic that is a shared domain of interest and disciplines. So Patrick, it's so great you're here. Thank you.
Likewise, thank you very much, Samantha, and what an amazing turnout. Great, well done.
You're a good draw, Patrick. I have
I'm not sure about that. I'm not going to put down to me for sure. So yeah, that's great. Thanks very much, everybody.
Yeah, it's great. It's so good. So I'm going to let you kind of take it ahead because
Great.
you have this whole approach. And would you like questions after, during? What's better for you?
What I might do is I just kind of might kick off with a presentation, and I'm keen then on kind of seeing what people would like to get out of it.
Yeah.
So would they like to get some practical exercises? Do they have questions? And so maybe at last, we have 1 hour, 1 hour sharp, is it? Or
oh yeah, we're on the
1 hour sharp. Okay. So maybe the last 15 minutes or so we'll have for questions.
Okay, sounds great.
And if I can do it quicker than that, if I can get through the PowerPoint quicker, we'll have a little bit more time for questions. So then it can be tailored. Just before I start, Samantha, if you can make me co-host as well, please. Oh, you've done that already.
Share.
Excellent. You have it. Great, great. Okay, let's kick off. This was an interesting document here. Some of you might have come across it, and it was published by the American Thoracic Society. And they were considering the mask selection that's used with people with CPAP. Now, the only reason I think it's good to highlight this is because maybe with myofunctional therapy, your emphasis is on working with people who are not on CPAP. But how about working with people who are on CPAP? Because when you see what we're about to discuss, you will see that even users of CPAP could really, really do with myofunctional therapy and breathing reeducation. So this is a 20. Yes.
Quick question. Could you press play on the presentation so it enlarges?
I can. Now, the only thing is with what happens is that it sticks. So I might have to go back. So we'll see how it goes, Samantha.
Okay.
Yeah.
Okay.
So this is the document. Now, inside in the document, I cut and pasted these images here. You can see image A, that the mouth is closed, or at least it should be closed. The tongue is resting in the roof of the mouth. And you see that the soft palate is forward, the epiglottis is forward, and the airway is reasonably open on the basis of having the mouth closed. This person is a nose breather, so they can wear a nasal CPAP. And the nasal CPAP is able to administer air at a flow sufficient to splint open this airway. But what about the person who has a stuffy nose, or what about the person who is a chronic mouth breather, given that 50% of adults wake up typically with a dry mouth in the morning, which would be an indicator of mouth breathing during sleep. So those individuals who are mouth breathers, the example here is in B, there's no indication or encouragement or help with those individuals switching to nasal breathing. Instead, they are administered a full face mask. And the full face mask does not take into consideration the impact of mouth breathing on the airway. So you see this individual, they have their CPAP on, but they are nasal or nasal breathing. Their mouth is open, their mandible is set back, their tongue is in the lower resting posture, their soft palate is falling against the throat, the epiglottis is falling against the throat, and the throat is narrow. So mouth breathing is fighting the very thing that the CPAP is hoping to open, the airway. And if we look at the advantages of nasal versus oral nasal breathing, and sleep doctors must be concerned with compliance rates in CPAP, in sleep apnea, because, for example, 85% of people with sleep apnea don't get diagnosed. Of the 85% that do get diagnosed, only 40% take up treatment. And of the 40% that take up treatment, only 50% of people that will stick with it. So if you have 100 people in a village with obstructive sleep apnea, typically only about 3 or 4 of those individuals are getting treated. And 96% of those individuals are not getting treated. So sleep medicine should be doing whatever it can do to help improve compliance. But if you have a nasal breather, they're much more likely to be compliant. Number one is because they have a much more comfortable mask. There's a lower overall leak. There's lower therapeutic pressure required because the nose with the tongue resting in the roof of the mouth is helping to open up the airway. And as a result, then the CPAP pressure doesn't have to be set so high. There's a higher adherence, there's a lower cost, less risk of aspiration, lower risk of CO2 rebreathing, and lower risk of aerophagia. In other words, there's a lot of advantages to nasal breathing, wearing the nasal breathing. Now, if we look at the disadvantages of oronasal, and you can see that the list is here, less comfortable, higher overall leak, higher therapeutic pressure required, lower adherence, because there's a much greater surface area. You have a mask that's in contact with a much greater area of the face, and because the therapeutic pressure is higher, because the mouth is open, the tongue is falling back, the airway is narrower. This, of course, is increasing resistance, so the CPAP pressure has to be higher, but that increases the risk of leak. And these individuals here are less likely to be compliant. So it would be wonderful if sleep doctors, instead of just prescribing an oronasal face mask, would be to administer nasal breathing and myofunctional therapy. It just doesn't make sense what they are doing. Now, if we look at, say, mandibular advancement devices with mouth taping. So this was a paper published back in 2022. And here are the results baseline. And this was quite a good study because they looked at adults with an AHI ranging from 5 events per hour, which would be mild, right up to about 45 events per hour, which would be severe, and everything in between. They used adhesive mouth tape here. So they looked at what was the impact if we simply closed the mouth. Now, the mouth tape that they used covered the mouth. And that's not good if you have obstructive sleep apnea because it prevents mouth puffing. So whatever tape that you use, in terms of a nasal breathing support, the individual must be allowed to mouth puff. And if they can't mouth puff, their sleep apnea can get worse. So you can see with adhesive mouth tape, yes, some people made progress, but some people got worse. And this individual here who got worse, it increased their risk of sleep apnea because they weren't allowed to mouth puff. Mouth puff is when air has to leave the body through the mouth. So you can see these individuals here, they were remarkably better. A couple of here got worse. Worse, better, a couple here got worse, and you can see the result there. Here's a mandibular advancement device. So this is a dental appliance obviously put into the mouth to help open up the airways anatomically, to reduce the resistance to breathing so that air can flow more freely from the nose, from the mouth, into the lungs. Quite a good result. But then what they did was they combined using mandibular advancement device and adhesive mouth tape. And it made quite a dramatic improvement. And the results were that 76% of individuals who achieved, sorry, I say that again, 76% of individuals achieved an AHI of less than 10 events per hour in the mandibular advancement and the adhesive mouth tape, in comparison to 43% of individuals who only wore the mandibular advancement device. So a point that I would make here is that if you have patients and they have a dental appliance in their mouth, it's also very important to teach them to breathe in and out through the nose and to use nasal breathing supports to help ensure nasal breathing during sleep. So there's a room for myofunctional therapy alongside, of course, mandibular advancement devices. One might ask the question why nasal breathing is often overlooked in sleep apnea treatment. Well, the focus is on the airway pressure. There's no focus on breathing. Breathing does not get a look in at all. Even though if you look at more recently the phenotypes by Danny Eckhart, which is including PAM, it's peak crit, arousal threshold, loop gain, and muscle recruitment. There are 3 phenotypes that are non-anatomical. And 69% of people with sleep apnea have one or more non-anatomical phenotypes. So sleep apnea is complex. And if one is to make some progress with reducing the AHI and improving sleep apnea, one would need to look at more than just the anatomical phenotype. CPAP is designed simply to work with the mouth or nose. It's not there to change habits. It's there to accommodate the habits. Nasal breathing requires retraining. It's not just equipment. That is a problem. It takes time, it takes coaching and habit change. Many clinicians assume mouth breathing is normal, and they do. You know, you can talk to doctors and they will sometimes tell you there is no difference whether you breathe through your nose or through your mouth. And they will say that, you know, but of course we know different. The lack of training or time to educate patients on nasal breathing. But this is why it's overlooked, but we have to take into consideration the whole impact of continuous mouth breathing while wearing CPAP and the whole impact of continuous mouth breathing while wearing mandibular advancement devices. And it's never just about getting the mouth closed during sleep. It's never just about forcing nasal breathing. It's also about training breathing behavior during the day, training it during wakefulness, helping to decongest the nose. And I will also say that if you have looked into the Buteyko technique, there are breathing exercises that are very effective in decongesting the nose to the point that you don't have to be referring on to allergists. You know, a stuffy nose, rhinitis or hay fever, whether it's seasonal or whether it's chronic rhinitis, you can still make quite a big difference to nasal congestion using breathing exercises. I put this diagram into a book that I've recently written called The Breathing Cure for Sleep, because, you know, resistance is a word that we often hear, but what does it mean? In very, very simple terms, what does resistance mean? And my take on resistance is the ease at which air can flow from the nose or from the mouth into the lungs and back out again. And when there's no resistance to breathing, breathing is silent. And of course, during sleep, this would be ideal, that the person is breathing, but the flow of air going from the nose into the lungs is going with such effortless ease that it's silent. Now, if you were to start breathing a little bit harder now, and you just increase the speed at which you breathe, you will start hearing your breathing. So here you have mild resistance, and always think about it. It's never just about the airway itself, but it's also about the speed and depth at which you breathe. So mild resistance isn't good. It's not too bad with adults, but it's definitely not good with children. We should never hear a child breathing. So with a child, ideally, they're continuously breathing in and out through the nose, tongue resting on the roof of the mouth, and their breathing is silent. The next stage of resistance would be moderate. Now, this is not going to be perfect. This is my take on it so that I could better understand it. So you might have some disagreement with it. That's okay. It's only to kind of show a visual and to show the different stages from no resistance to breathing to very severe and the impact that this is having, or how would you recognize it. So I put down moderate here is taking into consideration snoring, and that's turbulent airflow, either in through the nose or through the mouth, or both. We can stop mouth snoring pretty quickly once we get the mouth closed during sleep. And mouth snoring or palatal snoring. Well, certainly palatal snoring is the most common form of snoring, and you would expect palatal snoring to be most common with mouth breathing. Can you breathe? Can you snore through your mouth if you're solely breathing through your nose? So if we get an individual who is a chronic mouth breather, and if we can help that individual transition to persistent or habitual nasal breathing, we can pretty much stop mouth snoring, guaranteed. Because in order to mouth snore, you have to be breathing through an open mouth. If you're only breathing through the nose, you cannot snore through the mouth. Nasal snoring is a different story because of the turbulence inside in the nasopharynx. But turbulent airflow is never just about the airway. You also have to consider the speed and depth at which the person is breathing. A narrow airway, of course, increases resistance, but what's expected to go through this airway? If this individual is breathing very light through the airway, there's going to be reduced resistance. But if this individual is breathing very hard and fast, if they have a fast respiratory rate and they're taking quite full breaths into their lungs, there's going to be an increased resistance. So we can't just look at resistance to breathing without considering the flow that's expected to go through it. So severe resistance to breathing is when you have airway collapse here. So the airway is collapsing, blood oxygen saturation in an adult is dropping by 3% or more, lasting for about 10 seconds. And that's a hypopnea. And then when we have very severe resistance, the airway is collapsing altogether. And with this, no airflow can enter into the lungs because the throat pretty much has collapsed. So let's look at upper airway resistance syndrome. And I'm going to kind of go through the slides quickly. You know, this is a really, really interesting one. And I think you will find it, and maybe you know all about it, but it's the subtlety with it that's the problem. And also the fact that it impacts more women than men. And the symptoms associated with it can be different for women and men. So the whole area of sleep has evolved around men. If you think of a sleep industry, and it's worth what, about $6.5 billion per annum. And it's primarily aimed at men. See, men are very obvious poor sleepers when they have sleep apnea. It's very noticeable. They have very, very heavy snoring, and then they stop breathing during sleep, and everything is obvious. But what about when there's a narrower airway, such as here, and the airway is narrowing to the point that it's increasing resistance to breathing? But it's the increased effort to breathe associated with the increased resistance to breathing that takes the person out of deep sleep. That's when you're talking about upper airway resistance syndrome. They're not having hypopneas. Their blood oxygen saturation isn't dropping. They're not having apneas. They don't have 5 events plus per hour of sleep. So if they do a sleep study, they come back as negative. But what they do have is they have resistance to their breathing during sleep because of a narrower airway. And it's the resistance increasing the effort to breathe and the increased effort to breathe that's pulling them out of sleep. How many people go and do a sleep study and they have the symptoms of having poor quality of sleep, but the sleep study comes back and says there is nothing wrong with you? And also if we consider that, you know, the entire sleep industry evolving around men and tailored more so to men than women, women's symptoms with poor sleep are different to men. Women are more likely to suffer anxiety and panic disorder. They're more likely to suffer fibromyalgia and chronic fatigue and dementia later in life as a result of poor sleep. Men are more likely to be tired. So if you have a female and she's coming into you and she's suffering from mental health issues or for fatigue or fibromyalgia, this could be a condition worth investigating, upper airway resistance syndrome. So it doesn't result in an apnea or a hypopnea. It's a normal respiratory index, and it's the increased effort required to breathe that results in multiple sleep fragmentation. So he or she, and primarily this will impact more women. And the risk factors would be, say, a female with a high upper palate, dental extractions, a smaller mouth, so a narrower airway. Upper airway resistance syndrome aimed to understand what was historically not covered by obstructive sleep apnea. And this year is a 2024, but even in 2024, there's so little known about this condition. And it was first identified in children back in 1983, so children can be susceptible to it as well. And it was later identified in adults in 1993. So children is said it was 1982, sorry, and adults in 1993. So it was Christian Guilleminault who identified it first in children, 1982. And even this 11-year stretch, why did it take 11 years before this started to get some recognition in the adult population? And the reason being is because it is so subtle. You have somebody sleeping, they're not making any noise. They do their sleep study, it comes back as negative, but yet they have symptoms associated with the increased effort to breathe during sleep. So is it a continuum from snoring to obstructive sleep apnea? This paper here suggests that it isn't, that it's a distinct syndrome. It occurs in a distinct population, and that there is a false assumption that it forms a continuum between primary snoring and obstructive sleep apnea syndrome. So here they looked at 400 cases of upper airway resistance syndrome, and almost 1/4 of them had pure upper airway resistance syndrome. These patients frequently complain of insomnia, sleep fragmentation, and fatigue. Now, it's worthwhile talking even about insomnia. It's worth talking about low arousal threshold. And again, it does seem to affect more women than men. So insomnia is when you would be a very, very light sleeper, that you have difficulty going to sleep at night. Low arousal threshold is that it doesn't take a whole lot to wake you up. So for example, if your airway narrows just a little during sleep, that's going to increase the drive to breathe, or it's going to change, for example, the chemical drive. Carbon dioxide is going to increase a little bit, maybe oxygen decreases a little bit, there's increased effort to breathe, and that takes you out of sleep. So people with low arousal threshold, these individuals wake up very, very easy. And very often, upper airway resistance syndrome and low arousal threshold go together. And this again makes it complex. And you could argue that low arousal threshold is very often that a person is in an increased sympathetic drive, they've got hyperarousal, increased stress, increased rumination of the mind, and it could be worth targeting that from a psychological point of view. So we have psychophysiology, the connection between the body and the mind, and we can't differentiate that or isolate them when it does come to sleep, because there's often a crossover. So the craniofacial anatomy, it reveals a predominantly high and a narrow palate, an abnormally small intramolar distance, an abnormal overjet of greater than 3 millimeters, and a thin, soft palatal mucosa with a short uvula. In 88% of subjects with upper airway resistance syndrome, there is a history of early extraction or absence of wisdom teeth. Their psychological profile shows a high anxiety score. Now, is it that these individuals had a tendency towards anxiety anyway? Females are 2 to 3 times more likely to experience panic disorder than men. Females are more likely to ruminate than men. That's what the literature suggests. Were these individuals, more anxious individuals in the first place, or did they have lousy sleep quality because of the increased effort to breathe during sleep, and that in turn drove up their anxiety during wakefulness? And then, of course, the anxiety during wakefulness is going to feed back into low arousal threshold during sleep, hyperarousal. In upper airway resistance syndrome, the arousal threshold is lower. So I spoke about this. So the patient to wake up in response to small increases in inspiratory effort. So arousal threshold is the propensity to wake from sleep. If you have low arousal threshold, you wake up easy. If you have high arousal threshold, it takes you a lot to wake up. Somebody with high arousal threshold is, I'll just give you an example of a man. He stops breathing for 40 seconds and he doesn't wake up. But somebody with a low arousal threshold, they're breathing, there's an increased resistance to breathing, not all that much, but that in turn is increasing the effort to breathe, and that arouses them out of sleep. And when they do a sleep study, of course, they're not going to have a high AHI. Why? Because they've woken up. So they're continuous sleep fragmentation. They wake up at the slightest difficulty in breathing or the slightest resistance in breathing, and then this manifests or registers as a low AHI. Upper airway resistance syndrome, it has been discussed and researched for many years, and yet there is no clear consensus on the diagnostic criteria or whether it represents a distinct syndrome from obstructive sleep apnea. And that's a 2024 paper. So I doubt if there's any headway being made in the last 12 months or so. It's linked with many somatic, psychiatric, and psychosomatic conditions, including parasomnias, attention deficit disorder, attention deficit hyperactivity disorder, fibromyalgia, and also chronic insomnia. So the symptoms could tell you a tale when you see the symptoms and you see the profile, and that person does a sleep study and they come back negative. So while sleep apnea and central sleep apnea are defined by the number of apneas and hypopnea episodes per hour of sleep, UARS is defined in general as airflow limitation. So there's airflow limitation due to the increased respiratory effort, which is causing the person to arouse from sleep, but they don't have significant desaturation. And it is associated with daytime sleep symptoms. So these might be the criteria that if you have somebody and say, for example, you do have a patient and the patient is having anxiety and panic, they may have fibromyalgia, they may have chronic fatigue syndrome, and you suspect there's something up with their sleep, and you refer them to a sleep study, it would be very important that the respiratory effort related arousal is included in the results, because that's going to be the telling factor here. This is one way to look at it. UARS has been more specifically defined as the AHI is less than 5 events per hour. Oxygen desaturation doesn't go below 92%. So it stays normal. But the respiratory effort related arousal is greater than or equal to 5 events per hour. So this is the telling part here. Another study used a slightly different definition that the AHI, again, it's less than 5 events per hour. Blood oxygen saturation is normal at 92%, but the presence of airflow limitation during sleep for greater or equal to 5% of total sleep time, and daytime sleepiness and or fatigue. So 2 ways that you could have to recognize it in combination with the symptoms the individual has and the telltale factors such as high upper narrow palate, dental extractions, small mouth, etc. So these are the risk factors, OSA and UARS. So you have jaws that are set back, a palate with an extremely high arch, consistently enlarged tonsils, or a tongue that's larger than normal for the patient's oral anatomy. And the probing questions asked by the patient physician regarding poor sleep or sleep position, obesity, hypertension, morning headaches, or oral facial pain are also necessary identifiers. So if the primary cause of the abnormal breathing, such as a crowded airway and narrow jaws, are not corrected, patients will be left with complaint of worsening functional symptoms. So if the primary cause of the abnormal breathing, such as the crowded airway and narrow jaws, is that a medical problem or is that a dental problem? Primarily, we're going to say, of course, if narrow jaws are the issue and crowded airway is the issue, anatomically, then it makes sense for myofunctional therapy to be playing a significant role. The patient may complain of sleep disruptions and unexplained awakening from sleep, mainly after 2 to 3 hours of sleep. And that's common. 30% of people wake up frequently during the middle of the night. 8.6% of people in the United States take sleeping pills to help fall asleep. When you wake up at 3 o'clock in the morning, it's not easy to fall back asleep. There's a tendency for the mind to ruminate. And if you already have a stressed job or difficult family life or difficult situation and things that you're worrying about, this is when all of these things seem to come to the surface. So you are lying there in bed, your room is cozy, you might have adopted the best sleep hygiene, your bedroom is cool, it's airy, and you're lying there and you can't fall asleep because your mind just won't switch off. So what do? You could bring your attention out of your mind and onto your breathing. It's a brilliant way to help to bring a quietness to the mind, to get out of your head, to bring some gaps between thinking. And you could also start slowing down the speed of your exhalation to tell your brain that you are safe. So what are the options here? I found the easiest option, to be honest with you, is listening to a guided audio. That when you wake up at 3 o'clock in the morning, switch on a guided audio and hand the problem over to a guided audio, especially if it's scripted, with relaxation and also with breathing exercise to get you back to sleep. And it takes the pressure off you trying to fall asleep. So you might have patients coming into you, and again, they do a sleep study, and the sleep study comes back that they don't have sleep apnea, there's nothing wrong with them. But are they waking up because of low arousal threshold at 3 o'clock in the morning? The symptoms are going to be the same. They're going to be fatigued, they're going to feel irritable, and they will have difficulty concentrating. They will have cognitive difficulty. So I think it's very important to have little tools that you can help your patients who are waking up. These frequent unexplained arousals are associated with increased respiratory effort. So here's your UARS coming in, and lead to sleep fragmentation, resulting in fatigue and excessive daytime sleepiness. And in addition, individuals with UARS and obstructive sleep apnea have exhibited a low quality of life compared to the general population. So the treatment options for upper airway resistance syndrome include addressing the underlying causes of the upper airway anatomical problems such as nasal allergies. This is where breathing re-education comes in. You can show people how to decongest the nose, how to switch to nasal breathing, and how to improve the underlying breathing patterns. Our diaphragm breathing muscle is mechanically linked with the upper airway dilator muscles. When we think about breathing, we can't differentiate or isolate the upper airway from the lower airway. It's one airway. But if you have an individual who is sleeping with their mouth open, which is very common, they will be breathing fast, unconditioned, cold, dry air into their mouth, down their throat, contributing to trauma of the upper airway, but they will be breathing also upper chest. They will have a reduced tidal volume. They won't be using the diaphragm to the best or optimal recruitment as it should be. And as a result, then the throat is more liable to collapse. And when you breathe through your nose, you do have a better recruitment of the diaphragm. It increases tidal volume, and that in turn helps to stiffen the throat and prevents it from collapsing. So there's so many reasons going on that nasal breathing is so much more important, with the tongue resting in the roof of the mouth. Dental malocclusions, of course. I think the dentist has a huge role to play, absolutely forgotten about, overlooked in sleep, from children all the way up, and abnormal lifestyles, such as, say, overeating, drinking alcohol, etc. The mainstay therapy is continuous positive airway pressure. That's the mainstay of therapy. Surely there must be a better therapy for upper airway resistance syndrome. Where would myofunctional therapy and breathing re-education come in with this one? I think it could be huge because it's quite subtle. And it would be a very, very interesting one to target, specifically as it's affecting, it seems, more women than men. And it can affect younger women. It's not your classical symptom. It's not your classical person with sleep disorder. It's not your person that's over 50 years of age that has quite a few pounds on. It can be your young person. She's 30 years of age. She's fit, she's slender, but she has a smaller mouth due to dental extractions, but she can't function in work. She may not gravitate towards the CPAP, but she might gravitate towards myofunctional therapy and breathing re-education. So it's all about, bringing the two together. Breath hold time to assess your breathing patterns, decongest the nose, training the tongue to rest in the roof of the mouth. Of course, training is spent wrong. Retrain functional nasal breathing day and night. Reduce the chemosensitivity to carbon dioxide. Normalize breathing rate and volume. Breathe low with good recruitment of the diaphragm. Now, I know that may sound a lot, but they go hand in hand. Once you're working with somebody's breathing patterns, you start to train that. And it's also about reducing overthinking. And the thing is that if you experience insomnia yourself, you will know that it's challenging to fall back asleep, that the mind has taken over. And all of that racing mind, the continuous pattern of thinking, the broken record, as you just replay things over and over and over and over in your mind. How are we going to fall asleep when the mind is so active? It's very important to bring our attention and to get out of our heads during the day. And I will genuinely say, I spent 25 years stuck in my head, and I've spent 25 years bringing my attention out of my mind and onto my breathing and into my body and into present moment. And there's no comparison, because a life stuck in our head is a difficult life. And even just gently bringing your attention onto the breath, it helps to bring gaps between thoughts. It helps to slow down the momentum of the mind. And it helps us stop overthinking, because overthinking and poor sleep go together. Poor sleep causes overthinking, but overthinking causes poor sleep. And the next time that you have a poor quality of sleep, just check in on how often you will ruminate the next day, how often you're stuck in your head the next day. So there are parts of the brain that are associated with rumination called the default mode network. And more recently, there's been a couple of papers looking at it, the impact of nose breathing versus mouth breathing on the default mode network. So the default mode network refers to these different parts of the brain that light up, that are active when you go into mind wandering mode. And we as human beings, we spend about 50% of our time in mind wandering mode. But the researchers checked, is there a difference if you breathe through your nose in terms of the impact it has in the default mode network versus if you breathe through your mouth? When you breathe through your nose, the activity of the default mode network is less rumination, less overthinking. But if you breathe through an open mouth, the parts of the brain that are associated with speech light up, and the activity of the default mode network light up. And that's very, very important distinction to make. When we breathe through an open mouth, the brain thinks that we are communicating. The brain thinks we are talking. The parts of the brain associated with speech light up. We should be breathing through our nose. Because what is the brain interpreting when we are a persistent mouth breathing and overthinking when it comes to sleep? That's also going to generate a lot of symptoms associated with poor sleep. And of course, poor sleep is going to feed back into overthinking. So it kind of brings us full circle. That's my presentation. And you can see there's a couple of topics that I wanted to kind of look in on, because sometimes we forget about it, The person with the CPAP machine, the person with the mandibular advancement device, the person who goes to a sleep study and the study says that she doesn't have any sleep issues, the person with an overthinking mind. That also needs to be. A CPAP isn't going to address the overthinking mind, and a sleeping pill isn't a great example either. So, Samantha, the floor is open.
Fantastic. Thank you for leaving this time. I know we do have a lot of questions, beginning with mouth puffing. Can
Yes.
you explain that physiologic perspective? And you said when the body needs to breathe through the mouth.
It has to.
Mm-hmm.
It has to. We can't stop it. So the only way that I kind of figured out mouth puffing was I have an elliptical, the exercise machines that you kind of, and I ramped up the speed while breathing through my nose. And at some point when you're continuously breathing through your nose and your breathing gets faster and harder because of the exercise, at some point the air is just going to leave the body anyway, and it leaves through the mouth. So mouth puffing could be when you're breathing in through the nose. So this is when the air is so forceful that the body needs to get rid of the air very, very quickly, and there wouldn't be enough time for that air to leave through the nose, because see, the nose imposes a natural resistance to your breathing that's 2 to 3 times that of the mouth. Now you could say, well, it's the nose, it's the mouth that imposes the resistance to breathing during sleep. That's correct, but this is in the airway. But your nose will always impose a resistance to your breathing, because if you think of your 2 nostrils are smaller than your mouth, and if you're trying to expel air from the body, the nose slows down the speed of the air coming out. But if that individual has to forcibly breathe out, they have to be allowed to breathe out through the mouth. If you stop them breathing out through the mouth, their AHI goes up.
Okay. Also related to oral anatomy, you mentioned the uvula in terms of a characteristic. Can you share more about that in terms of identification and UARS, if it's connected?
So I think that's more myofunctional therapy. You know, if you're using the Mallampati score or different Friedman scores, that you identify it. You know, so it's outside of my scope, but I just shared it because I took that directly from the journal. But it could be risk factors that you were looking for. You know, because you're looking into the mouths, and yeah, it's kind of outside my scope. So
Okay.
that's a question for Mayo.
Okay, good. Well, we can answer that. It would be related to the soft palate and the musculature in that oropharyngeal area.
And you know, Samantha, I suppose it's always going to come back to the very things that we know here now anyway, with the mouth closed and the tongue resting on the roof of the mouth, that we're helping to pull everything forward and to pull the soft palate away from the back of the throat and to pull the epiglottis away from the back of the throat. But what would chronic mouth breathing do to traumatize the upper airway? And I don't know, I remember as a student, I would go out and I would be partying with like every other student. And I had sleep disorder breathing that was undiagnosed. And I can remember waking up some mornings and my throat was just raw. And my throat was raw because of this. And that's trauma. You know, and what's that going to do to the upper airways? And, you know, even when we look at speech language pathology and they're really looking at the vocal cords, how much of an emphasis is on protecting the vocal cords? How much of an emphasis is on breathing re-education to breathe in and out through the nose? I will always say to my own clients, there's nothing inside your mouth that does anything for breathing. Nothing. And you don't need to be a rocket scientist. You know, what's inside your mouth? A 5-year-old child will tell you this. Ask the next 5-year-old kid coming into your clinic, what's inside the mouth? Your teeth, your tongue, your hard palate, your soft palate, your gums, saliva. And then you can ask, what do those things do? What does your teeth do? What does your tongue do? What does the hard palate do? The saliva do? The gums do? Do any of those do anything for your breathing? And the answer is no. There's nothing inside your mouth that serves any purpose for breathing. Nothing. And if nature had designed the mouth to breathe, there would be something inside the mouth. So I would like you to come back to this mouth snoring, because it seems to be the more common form of snoring. It's sometimes called palatal snoring. And to make the sound of a snore through your mouth like this. Can you do that?
Yeah.
So now what I would like you to do is to close your mouth and try and snore through your mouth with your mouth closed. It's not possible. You cannot snore through your mouth if you're breathing solely through your nose. And now what I would like you to do is to make the sound of a snore through your nose. What did you do to make that sound? What did you do to the speed of your breathing? What did you do to the depth of your breathing? You just didn't tighten up the airway. It's not just an anatomical issue, it's a breathing issue as well. And if you were a plumber and you were going to a kitchen sink and you had to bring a pipe from the kitchen sink all the way back to the back of the house, you're not going to arbitrarily select the diameter of a pipe. You're not going to just guess it, pull it out of thin air. You're going to select the diameter of the pipe based on flow. it's really important that we consider breathing patterns, because our everyday breathing is going to influence our breathing during sleep. And dysfunctional breathing is common. 75% of the anxiety population have dysfunctional breathing. 75%. How do you recognize it? Mouth breathing, a little bit faster breathing, upper chest breathing, irregular breathing, and they often feel that they are not getting enough air. And that's going to impact sleep quality. If you have poor breathing patterns, you are more likely to have poor sleep. And poor breathing puts us into an increased sympathetic drive. And if we're in an increased sympathetic drive, we can have overthinking minds. We're not having balance of the autonomic nervous system. So I don't think we can differentiate between breathing, the very function of breathing in sleep. You know, sleep disordered breathing. All of the emphasis is on sleep and the disorder, and no emphasis on breathing patterns. But I do think it needs that kind of attention.
Harold, we'd love to have you step in the arena, ask a question. Go ahead and unmute yourself, Harold.
Yeah, thank you, Samantha. And thank you, Patrick. It's always fantastic to listen to you. I just have one question because in the surgical community, a review paper on mouth taping was getting a lot of attention this spring because they actively warned against mouth taping because of the danger of potential suffocating. So we had a very nice discussion in that group. And I said that we don't know any cases having severe damage from mouth taping. So I just wonder if you are aware of any cases with damage from mouth taping, or if we should in any way be able to communicate that it's not dangerous to do mouth taping during sleep.
I think it's a very good question. I've been encouraging my clients to mouth tape since 2002. And I typically had 600 clients per year. So I was very active. I can't remember. I had one incidence of a child in Poland that did get sick during the night but pulled off the tape. So that wasn't good. But other than that, in the 23 years, I haven't. I have never been sued. I've never been brought up or in trouble over it, you know. And the other thing is, like, I did bring out our own tape about 5 years ago, which is myo tape. And it surrounds the mouth. It doesn't cover the mouth. Because it was the instance of that kid that I was always apprehensive about, you know, how do we get children to breathe through their nose without covering their mouth? And the myo tape is kinesio tape that comes around the mouth. And this has been used in I've seen precedents in PubMed using kinesio tape in newborns. So professionals that are using kinesio tape surrounding the mouth in newborns. So it's in PubMed. We've sold 12 million strips, Harold. We have professional indemnity insurance. We have product liability insurance. So, you know, we haven't had an adverse reaction, and I'm hoping we don't. So I think if you look at the numbers of people who are keeping their mouth closed, and this is caught on for a reason. People are not just paying money just for the fun of it. If you ask large groups of people, do they close their mouth at night? Are they using a nasal breathing support? And has it made a difference to their sleep? And they will say yes. And it made a huge difference to my sleep. I was exhausted waking up in the mornings. And learning to breathe through my nose with the tongue resting in the roof of my mouth made a huge difference. Now, I will say this. We should never force nasal breathing. So I do think that doctors absolutely have valid views. But the doctors themselves need to try it themselves. Because there's clinical experience and there's research experience. There's, you know, opinions and clinical experience. And I feel that if sleep doctors started using it with their patients and teaching them myofunctional therapy and nose breathing with the tongue resting in the roof of the mouth and seeing the difference, I don't think they will go back. But I do get their concerns. Mouth puffing is a problem. We have been lucky enough with myotape. It allows mouth puffing. And I'm not just saying it because it's my own product. But what I would say is, all of you here, there's 100 of you here, whatever, could you get into trouble if you were to ask a client to use a tape going across the mouth and it had an adverse reaction? And you're better off steering away from trouble. So whatever support that you use, have it that it surrounds the mouth but doesn't cover the mouth, because once it surrounds the mouth, it's not a mouth tape then. It's a nasal breathing support. So I think it's important for yourselves as well. But coming back to Harold, the risk is very, very minimal. It's very minimal. I think it's more a perceived risk than an actual risk.
Mina, do you want to unmute yourself?
Thanks, Harold.
Yeah, thank you, Harold.
Patrick, it's great. I was very amazed to see the difference of upper airway. I'm a pedodontist. I've been trying to use that for helping my younger patients to breathe through nose. I know they are more sensitive, so you have to introduce very slowly. And I did use the mouth tape, also my daughter as well. I do start with the morning so that they don't get too like overwhelmed at night, but start like 10 minutes, 5 minutes, whenever they watching TV, they're not really focused on the tape. But one thing that I got some complaints about the mouth tape, I use it, not the myo tape, but I use something available on Amazon, like, Japanese, like special mouth tape,
Sure.
because I didn't know
Yeah.
about the myo tape. And
Sure,
then
sure.
a little skin irritations because
See,
of the tape.
yeah,
So
but
do you have any suggestion or anything that
I
you
do.
experience?
Like even with the 3M 1-inch micropore tape, which is pretty much in every hospital in the Western world, I was having skin irritations with my own clients. I think that you're never going to get it 100%. Now, we've seen in some instances with myo tape that when a child is wearing the tape around the mouth and sleeping with it, now we would have established that they're nasal breathing, first of all, that they can do it. But if the child is trying to prise the mouth open during sleep, there's a stretch pull, and this is going to cause irritation. So I would feel that if you see irritation on a child, they need myofunctional therapy. They're trying to open their mouth during sleep. They need breathing re-education. They're not quite ready for it yet. And maybe the other thing is with the myo tape, it was stretched just a bit too much. So it can happen, and I think it's going to happen with any tape, genuinely. Because I did see it happen with 3M anyway. But yeah, so when children do come in, if they have a red mark as a result of wearing the tape, I wonder, were they trying to pry their mouth open while wearing the tape on? And then we have to consider how well are they able to function breathing through the nose, that we're not forcing nasal breathing there.
Patrick, you were talking about we were talking about the muscle function, the reverberations. I wanted to remind people there is some research looking at the vibrations of snoring and what that does to the cells themselves. I'm kind of looking at a group out of Umeå, Sweden, talked about axonal degeneration with snoring. So, there's a physiologic and physical experience of snoring. On the Fairest 6+4, which is a sleep assessment protocol for sleep disordered breathing, the last characteristic is to assess for palatal flutter. And this is where you ask the patient to elevate the tongue or basically lower the tongue, make the snoring sound, and now elevate the tongue and make the snoring sound. And if you can make that snoring sound with the tongue and the suction posture, then based on this Pong-Rottenberg kind of extension, the idea is that you manage expectations that myofunctional therapy alone won't fix the snoring. You might need orthodontics, surgery, but I'm proposing you may need breathing re-education. It is very possible that the breathing re-education can also, based on what you're describing, I think you see it all the time. When you fix the calibration of volume in the body, the snoring reduces and the vibrations reduce and that airway collapse reduces. So I'm just curious what you think about that.
Yeah, I don't know, Samantha. I'm not familiar with that study that you may study. I did actually try to snore with my tongue resting on the roof of the mouth, and I found it impossible because I can't breathe through my mouth anyway. When my tongue is resting at the roof of the mouth, it's blocking off everything. So I don't know. I'd have to look into it. Sorry. Yeah.
Okay. We talk about it a lot in our myofunctional therapy assessment, but it's also kind of the perfect marriage between breathing reeducation and myofunctional therapy. So to that end, I do want to say that we have a collaborative program, and we have a course that looks at breathing reeducation through the lens of myofunctional therapy, and it's launching in November. So if any of you are interested, the link is here. I highly recommend you learn about breathing reeducation, the Buteyko method, and then you have additional support as a myofunctional provider.
Yeah, and there's quite a few PowerPoint presentations, and the PowerPoints, say for example, that I covered today is one of them. But there's about 14 or 15 different PowerPoints for sleep, so it looks into the theory of it. I've written a new book on sleep called The Breathing Cure for Sleep, and all of that information is pretty much in the training portal, where we break it down, and we also then look at breathing, because very often I feel that breathing pattern disorders, it's forgotten about in sleep. Myofunctional therapy, of course, is very often overlooked, and the two go hand in hand. And when we consider that 85% of people with sleep issues are not getting diagnosed in the first place, we have a lot of work to do. We really do.
Well, we're on the hour. I can't believe it. We made it.
You can't believe.
This was a really fascinating dive, and I know that a lot of you have more questions. I just love that we're all so interested and curious. It's so fantastic we have this community. Please reach out to me if you have additional questions. We really want to grow in terms of bringing this forward. And thank you to the researchers in the room. Harold Strom, who asked the question, is part of Sleep Revolution and looking at myofunctional therapy in the sleep realm, among other things. So I just want to say thank you for joining us. It's such a great community. I love seeing you. So we will see you again soon. Thanks so much, Patrick.
Thank you so much, Samantha, and to everybody, and many of the faces I recognize. So great to see you all again. So thanks so much. Take care. Bye.
Yeah.